We'll move straight into our first speaker, who is Clinical Professor Cliff Hughes. He is a cardiothoracic surgeon. From his experience, that's what he's done largely in New South Wales Public Service, was at Royal Prince Alfred Hospital. He's someone who's passionate about patient-based care, clinical leadership, better incident management and reporting, and progressive quality improvement, and currently brings that to his role as the Chief Executive at CEC, which is a statutory health corporation here in New South Wales, established to promote and support improvement in safety and quality of New South Wales health services. So without further ado, I introduce to you Professor Cliff Hughes. There you go.
Thank you, Alison. Thank you to the organisers for asking me to come and talk about what we're doing in health to deliver on some of the issues that require us to understand how our system works. And you can see that I'm drawing a parallel between the beach and the bedside. And there's no surprise in that, because what we do in our beaches was something that unlocked what was not happening in our hospitals. Many of you will have been into the hospitals and seen on the end of the bed a conglomeration of bits of paper with various charts that were meant to display the condition of the patient. Problem was that they caused so much confusion that people weren't quite sure what the condition of the patient was. And that was distracting them from simply looking at the patient and determining that this patient actually looked sick, or feeling worried about the patient and not quite sure how to convey that message to the others in the team who would be needed to come and help. So we had a problem, people dying unnecessarily and quietly in our hospitals when they didn't need to. And we needed to find out just what was going on. And traditionally in health, we look at the numbers. We get a whole pile of information, data, evidence, and we pore over it and we try and solve a problem. But I'd like to suggest to you today that although that's crucially important, and I don't deny the value of research at all, in fact we do quite a lot of it, but we need to understand that quite often the narrative is more important than the numbers. The story between what happens and what could have happened often unlocks the solution to our problem, not just in health but in many other industries as well. And some of you will know about Safety 1 and Safety 2 thinking. This is about Safety 2 thinking. What actually worked in the system so that when something went wrong, we can identify what the problem was. And this is just a little model of how we work in health. And you can see a whole lot of buttons up the top there where we see major issues that we need to address, one of which is culture. And culture is important in health because the senior consultant often determines that culture in his or her ward or in his or her unit. And we heard many times, don't bother me between 11 o'clock and 8 a.m. in the morning. You're on duty, son, you fix it. What do you mean you're calling me? Don't you know what you should be doing? That sort of culture is long gone, fortunately, but it still exists in pockets. When we began to look at the human factors that were taking place in these wards where people were dying, we realised that there were some stories to be told. So we developed an incident information management system, IIMS, as you can see on the top of the flowchart there, where we looked not only at root cause analyses, but any incident that a staff member chose to notify the system about the way in which the system was performing. And then we analysed the narrative. We had the numbers. That program is hugely successful and one of the biggest reporting systems per capita of health staff around the world. But the numbers were not as important as the story. So we began to read the stories and realised there were times when we needed to rapidly investigate, talk to the family about what was going on because that's what they wanted to know, and then find ways to solve the problem. And when we looked at that narrative, one of the most common things were people dying on the ward without being recognised. So we started a program which I'll explain in just a moment. When we got that program running, we realised that the reason for that program to be successful was simply to treat infection. So we developed a sepsis program, a program to manage pneumonia. In the sepsis program, we needed to sepsis-proof the system, and that was as simple as getting people to wash their hands. When we first started, 28% of doctors were washing their hands before the first patient contact. I can report to you today that we've got that up over 70%. That's fantastic. We've still got almost 30% of people who don't. So we've got a way to go. But we also needed to treat sepsis successfully and make sure that people got antibiotics quickly. And that was another one of our programs that we developed. But let's go back to what was really happening on the wards. This is a summary of the reliability of observations that were being taken by our nursing staff. And you can see that this is done by 4 months. And you can see when we drew people's attention to the fact that the observations weren't being reported, they rapidly improved the reliability of the observation, with the exception of the one in the middle, which is a respiratory rate. Even though we drew it to their attention, they were still not doing it. So we went back and said, why? We asked the question. And they said, because it takes too long. All the other things you can get off the monitor. Respiratory rate, you've got to stop and count. So we realised what the problem was. We had to do something about it. The other thing was, of course, all the results were being compiled in one chart, which was confusing, and respiratory rate was just another line, and no one was paying any attention to it. So we changed the whole environment within which we were trying to deliver this program. And we introduced a chart based on the yellow and red of the lifesavers, whose job it was simply to watch the swimmers. What we wanted was our nursing and medical staff to watch the patients. And we introduced this standard adult general observation chart, amongst other things. We had an education program for 108,000 staff across the state. We had an education program on why people deteriorated. But this chart here set the environment in which we were going to deliver care from now on. And in the middle of January in 2010, on a Monday morning, this chart became the standard chart in every hospital across New South Wales in the public system. There was a little research group taking place in a few hospitals, which I'll talk about towards the end of this presentation. But every other hospital, large or small, used this chart, so that residents, interns, who move every 10 weeks, often at most, knew how to look at the observations from day one. That nurses could look at an observation, and if the observation was placed in the white zone, they, like the swimmer between the flags, were safe. If they put the observation in the yellow zone, they were required to take certain actions, and these were not mandated actions but suggested actions. And the first was, go and talk to a senior colleague. Have a discussion as to what's going on. Is this patient really sick or not? So we'd taken away one of the barriers to the problem. They now had some objective evidence that something was going wrong. And if they entered an observation in the red zone, that was mandated that they immediately call a medical emergency response team to come from the intensive care unit, or if in a small hospital in the country, from even the paramedics at the ambulance station, to come and help resuscitate that patient. And we give them a tool to escalate their concerns. One tool to identify their concern, another one to escalate their concerns, and see if we could drive change. And we separated out all the observations. There was now clarity of thought in what was really going on. Any one of those observations in the yellow zone caused people to think. And funnily enough, temperature, which so many people rely on, is the least sensitive. The most sensitive, in fact, is the breathing rate. And we know that because mothers would come in and say, Johnny's sick, he's breathing too fast. Or old people would come in and say, Uncle Tom is really sick, his breathing is laboured. So if the families knew it, why didn't the staff know it? And why didn't the staff respond? So we had to change the environment. And this single piece of paper, it's actually an A4 sheet on both sides, so there are actually 4 pages to it, has changed the environment in which we deliver healthcare in New South Wales. But we had to engage people. We had to have the clinicians involved at the coalface. And we needed to make sure that they were all involved, including those consultants who wanted to stay at home at night. And if a red call was instituted, they were notified. They ought to come in straight away and see what's happening to their patient. We had to get the local health districts involved because they were the executive sponsors. We had to get the ministry involved because we had to do a whole lot of support around this piece of paper to make sure that it was rolled out across the state. Actually, when the forms arrived in December of 2009, The nursing staff grabbed them and said, "This will work, let's use it now." We decided to do an evaluation of the program, and we approached a psychologist, a organisational psychologist, who said, "Cliff, we don't have to evaluate this, it will change the way we do things." I said, "How can you possibly say that when you haven't started?" He said, "Well, two reasons. Firstly, my wife's a nurse and she's already talking about it. And secondly, you've changed the environment, and if you want to change culture, you have to change the environment." Then we had to go to specialty groups like the Children's Health Networks. So instead of having an adult chart, we introduced not one but 5 paediatric charts which are age-related, with appropriate colour coding to make sure that people could identify that quickly. But we still had the problem that the ambulance service, which comes under New South Wales Health, was sitting outside our hospitals. And we showed them what we were doing. And the ambulance service has come back to us and said, "Cliff, we want to have this in our ambulances so that we don't actually have to transcribe information from our ambulance system to the ED system to the ward system. Can you institute that in our trucks?" And the answer is yes, and we're doing that as we speak. Does it work? Changing the environment always works. This graph shows what's happened. The blue line is the rapid response to those yellow zones. The red line is the cardiac arrest when everything fails. The mortality of a cardiac arrest call is around about 85%. Using that as a parameter and using traditional trends, we've been able to show progressive improvement over the time of our project. And you can see in this program that we've actually saved 28% of the cardiac arrest calls that we used to see. That's saving around about 1,200, in fact, at the last count, 1,197 lives since January 2010. If we want to deliver safe, effective health care, we had to change the environment. And it was simple as changing a chart. Thanks very much.
Thank you. Do we have any questions for Cliff? Would anyone like to ask something directly of him? Over here. We've got a microphone somewhere. Thank you.
Yes. Thank you. It's Louise Elliott from the Tax Office. I wondered, that's a paper chart, whether you were going to move into electronic channel at all, or...
Yes, we have done that. In the EDs, it's in electronic form, and we're gradually rolling that out. What we wanted to prove was that the culture is more important than the mode of delivery, but electronic is by far the best way to go, and we're moving there.
Thank you. Any other questions? Over here. Great, thank you.
Thank you, Lee McCauley from New Zealand. I just wondered if you had any areas you were planning to take this out into the future.
Yes. We had some pushback from some parts of the health system. The midwives and the obstetric nurses said, mothers aren't sick, it's a normal part of life. And we said, but what happens when they have a bleed or when they have a clot form or other problems go wrong? So they said, well, yeah, we need a form, but let's not call it a patient form. Why don't we call it a mothers at risk form? So we've moved into that area. I've mentioned we're moving into the ambulance area, and we're starting to have some discussions with some of our Medicare locals, or whatever they're going to end up looking like, about how they can actually have a similar process which identifies a person to the ED long before the patient arrives.
Thank you. We'll have some time for questions at the end, if that's okay with people now. At this point, I'd like you to thank Cliff for his presentation today. Thank you. Some pretty compelling results there. Our next speaker is Tony Newbury, who's the Executive Director and Chief Commissioner of State Revenue for New South Wales. Tony started his career in the Australian Tax Office. Is that the first? That was the first start, Tony? The Australian Tax Office, and has been in the Office for State Revenue here in New South Wales since 1985. He leads that office now, and certainly when I came into this position, I was aware that OSR had been early adopters of BI in New South Wales, and they've done some randomised controlled trials that, as you know, we've showcased in the document talking about BI's application in New South Wales. But he's going to tell us some more about that now. Thank you.
Ladies and gentlemen, thank you for the warm welcome. Given what the Office of State Revenue sometimes does to some of you, I have to say it was probably more than generous. Are there any fine payers in the room? Come on. If you are, thank you for your continued patronage. It's my great pleasure to talk to you today about OSR's experience with BI. We are big believers in it, and I will give you some examples a little later of where we've used it. But before we start, perhaps I could just tell you a little bit about the Office of State Revenue so you can put what I'm about to say into context. We collect the majority of state taxes. We collect land tax, payroll tax, stamp duty, gambling taxes, and from the 1st of July this year we'll also collect mining royalties. This year state tax revenue will top $20 billion, so that's a fairly significant amount of money. We also process fines on behalf of government. This includes fines issued by New South Wales Police and also camera infringements from fixed and mobile speed cameras and also red light cameras. We process fines on behalf of the government, but also on behalf of a number of, other agencies such as local government. We've got about 230 non-government clients that we collect fines for. This year we're going to process about 3.3 million fines, and the total value of those fines is around $670 million. We also manage debt on behalf of the government. That's debt that comes from our own sources, such as taxes and fines, but also debt on behalf of other agencies. We're about to start collecting debt from ambulance and from other agencies in the future. Over time, we expect this part of our business will grow as more agencies decide that we're probably better placed to collect debt on their behalf and allow them to focus on their core business. The last thing we do is that we administer a range of grants and benefits on behalf of the government, including first homeowner grants, stamp duty concessions, regional relocation grants, payroll tax rebates for businesses taking on new employees, and unclaimed monies. The total value of grants that we administer is around $330 million. So next year, OSR will be responsible for revenue administration activities to the value of around $23 billion, which is, I'm sure you'd agree, a fairly significant slice of money. Okay. We started our BI experience in November 2012 when the New South Wales government invited Dr. Rory Gallagher across from the UK government to assist New South Wales to apply BI across the public sector. We worked with Rory and Z Soon from Premier and Cabinet to have a look at our processes and our interactions with our clients to determine which would be the most fertile ground for trials in BI. And we agreed that really debt recovery in both taxes and fines was would probably give us the best opportunity to assess the effectiveness of BI as a tool to improve business outcomes. We decided to implement BI in two phases. Phase one involved the use of control groups to compare outcomes from the use of BI-inspired notices with non-BI notices. And if the BI notices produced superior outcomes to the non-BI notices, phase two involved the rollout to the entire client base. Since November 2012, we've conducted over 10 successful BI projects covering areas such as infringement penalty notices and reminder notices, land tax legal notices, enforcement orders for unpaid fines, time to pay reminder notices, particularly using SMS technology, payroll tax notices of investigations, and payroll tax seminar invitations. Now, in the short time today, I really only want to focus on two of those projects and the outcomes that we achieved. The first involves penalty notices and penalty reminder notices. Now, just to give you a little bit of background, we issue penalty notices for camera recorded offences and penalty reminder notices where the infringement is actually issued by somebody else. It might be New South Wales Police, or it might be local government for parking fines and things like that. It's very important with these notices to ensure that it's very clear about the offence that's been committed and the options available to the recipient to resolve the fine. Applying BI to our penalty notices and penalty reminder notices was really one of our first forays into BI. It might be a little bit hard to see, but on the screen, on the left-hand side is the old penalty notice form, and on the right-hand side was the new BI-inspired form. The differences between the two forms were really more subtle than dramatic. And we co-designed the form on the right with Rory and Z based on theory and evidence from BI literature, results from trials in the UK, feedback from our own staff, and any practical barriers and requirements that we had to meet, particularly legal requirements. We used 5 techniques from BI. We tried to simplify the layout, the languages and the messages. We tried to clearly show the actions required and the consequences of not following through with those actions. We tried to use escalating tone through language and colour. Social norms, so we highlighted the fact that the majority of people do in fact comply with their penalty notices. And we tried to personalise the form as much as possible. So instead of saying things like amount owed, it said you owe. Now, one thing you might notice in the form on the right-hand side, in the top left-hand quarter, is a little stamp, pay now. We used actually different stamps during the trial to test their effectiveness. We used pay now and we used other little messages like act now. Now, the results of the trial. We sent out notices to approximately 180,000 fine recipients and control groups of a similar size. At the completion of the trial, 60.4% of recipients of the BI notice had paid by the due date, compared to 53.5% on the standard notice. That's an increase of 6.9% from the BI notice. So that's a pretty significant improvement from that BI-inspired notice. If you were to apply that rate of improvement across all penalty notices and all reminder notices issued by OSR in a year, it amounts to, in round terms, over 160,000 more fine payers paying by the due date, and an additional $32 million in fines being paid by the due date. Fairly significant numbers. When you consider the cost of carrying debt and the additional effort required by OSR to collect fines not paid on time, the benefits, I think, are obvious and significant. But the benefit is even greater when you consider that those 160,000 who would not have paid on time and who are now paying on time, once they go beyond the due date, they incur an additional fee of $65, which just makes the fine that much harder to bear. If those 160,000 don't have to pay $65 extra, that's a saving to the citizenry of $10 million per year. Within the overall 6.9% improvement in on-time payment, the percentage of notices paid within 15 days was 45.6% for the BI group compared to 39.2% for the control group. So not only were we getting more payments by the due date, we were getting them much earlier than the due date, suggesting that the notice was a real call to action. In that same notice, we also took the opportunity to use BI techniques to promote OSR's preferred low-cost payment options, such as BPay, Direct Debit, IVR and the web. And as a result, fine payers using our preferred payment options increased from 76% for the control group to 78.8% for the BI group. As a result, the unit cost per payment dropped by 3.6 cents. And while that would, on the surface, appear to be a small improvement, it will result in savings of approximately $100,000 a year in the cost of all fine payments. So that's, again, a fairly significant saving on the cost side. We also believe that we'll save about $80,000 in printing costs from not having to issue further notices to people once they've paid. So we thought that was a fairly successful intervention. The second BI project I'd like to talk about involves land tax legal notices. We issue around 160,000 land tax assessment notices each year, usually from January to March. The value of assessments issued in 2014 was around $2.2 billion. And land taxpayers can either pay their assessment in full within 40 days and receive a small discount of 1.5% on the amount owing, or they can pay it in 3 instalments over about 3 months. If the taxpayer has not paid by the due date, we send a final notice giving them an additional 21 days to pay, but interest starts to accrue on that debt. If they fail to respond to the final notice, we issue a notice of intended legal action, and that's what this particular trial was about. We set about changing that notice to encourage people, through the use of the BI techniques again, to pay on time. We deliberately chose taxpayers who had a consistent history of non-payment for this trial, so that we gave it a really solid test. In phase 1, we sent a BI version of the notice to over 1,000 land taxpayers and a non-BI version to about the same number. In phase 1, the BI group, which is the dark blue bar on the chart, returned payment rates of 39% compared to the control group's payment rate of 27%, which is the green bar. In phase 2, we repeated the experiment by sending the BI version to a larger taxpayer group, but this time without a control group. We thought we already have the control group results. The results of phase 2 weren't quite as good. This time, payment rates of 34%, which is shown in the light green bar, were achieved, compared to 39% in phase 1. Although payment rates dropped in phase 2, they were still vastly superior to the first control group payment rate of 27%. So they're the 2 examples. There are, as I said, 8 other examples, and they're all suggesting that you can make real improvements through the use of BI, and that those improvements so far, it's still early days for us, but those improvements appear to be sustained. Okay, moving on. We want to now embed BI within OSR. We're totally convinced of its value, and we really want to make BI business as usual. We're developing training modules to train all OSR staff in the use and value of BI, how to conduct BI projects, and use control groups to measure success. We're encouraging each business unit to adopt and use BI itself, because we don't want them to see BI as something handed down from on high. We want it to be embedded in the business owns and controls it, and understands it, so that it can carry out its own BI initiatives and improvements. We are keeping, though, corporately an inventory of lessons learned, which really documents all of our BI projects and their outcomes, and they'll form part of our knowledge management repository for BI. We've got an internal BI governance structure, which is a steering committee which really coordinates and just keeps an eye on BI across the organisation. And finally, we will engage with and be part of any active networks of BI, so that we can share our experiences but also learn from the successes and the failures of others. In conclusion, it's fair to say that I approached BI as an agnostic. When I was first asked to meet with Rory back in 2012. Like most of you, I guess, I'm a little cynical about fads and gimmicks. Let me assure you BI is not a management fad and it's not a gimmick. It's the real deal and it works. I've gone from being an agnostic to an enthusiastic convert, and I wouldn't be here today talking to you if that wasn't the case. Put simply, BI is a low-cost opportunity to improve business outcomes, reduce costs and increase your clients' satisfaction with your products and services. Thank you.
Thank you, Tony. I'm sure you all got a lot out of hearing him talk about those examples and how it's been applied very effectively in OSR here in New South Wales. Does anyone have any questions they'd like to ask of Tony? Over here? If we go over here first, great. Thank you.
Hi there, I'm Lani Perez from the Commonwealth Department of Environment. We're thinking of doing a trial similar to yours with the penalty reminder notices, and I'm just interested in, like you said that you used 5 or so techniques within the one notice, and I'm interested in how you figured out which technique was actually effective in changing the result when you were using a number of different techniques together.
Well, I think that's where, one of the key things about BI is that you've got to have good measurement in place. If you're trialling more than one technique, you've got to be able to measure the impacts of the different techniques. And I guess one of the risks is that the more permutations you've got of different BI strategies and interventions, the harder it will be to measure what actually works. So my suggestion would be to keep it simple, to be able to measure between the different interventions on the basis of only one change rather than multiple changes, because then it's hard to really tell which thing worked and which didn't work as well.
Thank you. Any other questions? Over here, we've got time for one more. Okay, great, thank you.
I can't hear well, but go on.
The payment methods, I noticed you took off the mail one, and you said that was obviously not your preferred way of receiving payment. Did you get any backlash for that, particularly from older people that might not have access to the internet?
No, there was no backlash. I mean, it's true to say that the front page, there's a front and a back page of that form. The back page has got all of the payment options on it. So the front page only lists, our preferred, and the back page lists from our preferred to our least preferred. Our least preferred, I hope there's no one here from Australia Post, is there? Is Australia Post, simply because it's about $1.70 a payment, whereas some others are less than 10 cents. But all the payment options were actually listed on the back page of the form.
One more question. We'll take that question.
Hi, Tony. Thanks for that. I'm Anne Cosgrove from New South Wales Business Link. I'm particularly interested in you talking about embedding BI in OSR, and I'd like to know how you intend to do that. What form is it going to take, and who are the providers? Is it going to be Rory and his team, or do you have other providers you're going to use?
So I believe the question was about how we're going to embed BI?
Yes.
Yeah. Look, now that we've done a number of trials, organisationally, it's going to be part of the way we do business. So, in a sense, that's handed down from on high, but we don't want every BI project to be handed down from on high. So, it really is now, it's been identified in our strategic plans, and it will be identified in our business plans for 14-15 going out, that BI is to be rolled out to all of our notices to clients, to all of the things that where we actually communicate with our clients, where we're trying to get them to respond in some way or to be informed. So a really good example is those 3.3 million fines a year. A proportion of people write into us and saying, look, the dog ate my homework, can I get off the fine? And we take those representations seriously, and some people do get off the fine because of the circumstances that they're in, some people don't. But what really annoyed me was that every time that we wrote back to them to say that the fine was to stand or the fine was waived, it was a letter that probably went for about a page and a half. Now, we don't want them to do anything with that letter other than to be informed by it. They might have to still pay the fine. So what we've gone to is a simple one-pager that is almost in, I guess, dot point form. It says, here's our decision, fine to stand or fine waived. Here are our reasons, dot point, dot point, dot point, dot point, and here's what you need to do next. And so that's just one example of where we're rolling it out. And we'll just keep rolling it out, and we will obviously keep a track of it because we want to know what the successes are. But it's just a matter of saying to our staff in our business units, BI is part of the way we do business, and it's going to be part of the way we do it ongoing.
Thanks, Tony. Okay, thank you. If you'd like to join with me now in thanking Tony. I would encourage everyone to try and find speakers afterwards, immediately after, if you've got a few minutes, if there's some more follow-up questions that you'd like to ask and we might not get opportunity to ask with the whole panel here. We'll see how we go. At this point, we're going to change it up and move on to Dr. Liam Smith, who's going to present to us on his work at Monash University with Behaviour Works, and then Jerril Rechter from Vic Health will be the last of our speakers today. So Liam Smith helped establish Behaviour Works at Monash, and as director has overseen the significant growth since inception, and you would see the areas they've focused on there are very extensive, focusing on human behaviour and behaviour change across a wide range of areas: water, energy, waste, litter, pollution, climate change adaptation and wildlife conservation. So I'm sure he's going to have many insights to share with us. Dr. Liam Smith, thank you.
Thank you. I'm not sure if this is the right presentation. We'll find out. No, this is the wrong presentation, sorry. So we had one that was sent through late on Friday.
No, that's the one. That's all I've got. Sorry.
Okay, well, we'll persist. So I might skip through a few slides because I was told to cut down my slides dramatically, and we'll see how we can do. I was going to introduce Behaviour Works, but I won't. I am going to talk about a particular trial that we have run in collaboration with a number of partners here in New South Wales. These partners include the Office of Environment and Heritage, Department of Premier and Cabinet and Rory's team, Green Steps, ARTD Consultants, Institute for Sustainable Futures, and a group called Field Force. This trial is a really interesting collaboration, and I hope to reflect on some of the lessons that we learn collectively as part of that. So I guess to start with the program itself, the Home Power Savings Program was a program established, I think in 2011, looking at trying to get low-income householders to use less energy inside their homes and to take control of their energy use. It set an ambitious target of 20% reduction in energy use and was designed to be delivered to 220,000 households, low-income households across New South Wales. Essentially involved people like this person here on the left-hand side, Deanne Lyle in Broken Hill, who is an assessor, who goes into a low-income household and reviews the circumstance of the house, installs or hands over some energy efficiency kit, things like energy efficient light bulbs, door stoppers, and shower heads and the like, and then uses tools like this PowerMate down on the bottom right as you look at it to inform, I guess, the consumer about how individual devices might be using energy. About 1 week after this, perhaps a little longer, the household is then sent, or was then sent, a letter so-called a Power Savings Action Plan. And that plan contained a sort of introduction part, outline of how some of the rebates that you might be able to access and incentives you may be able to access for installing particularly kit, some tips about how you might save energy, and how much you could save in terms of both energy and bills, and then a few more tips, and then a few more tips. And so this was the standard practice about a year ago, or perhaps about 18 months ago now. So I just want to say something about the lead up to the home power savings trial, which was kind of really important for allowing us to test some different things. I think there was some feedback that had come through the both focus groups as well as the feedback line that really showed that although people signed up for the program because they get this free stuff, at the end of it, they really appreciated the contact they had with the assessor themselves. Assessor would spend about an hour inside each home, and that was seen as a really valuable part. And so about 83% of the compliments that were being received by a household were complimenting the assessor, not so much the free kit. A review done by the Institute of Sustainable Futures had also been undertaken that showed that they were getting a savings around about 4%, varied a little bit higher sometimes. But that savings was largely coming from the kit that was installed. None of the behaviour change seemed to be making a big difference. And I think a third point that sort of thinks about the conditions that were present to allow a trial to become part of the agenda going forward were that the program, after a pretty difficult start, having to, it's ambitious to service 220,000 households. After an initial difficult start, was actually running on time and on budget, in fact ahead of time and ahead of budget. Now all these conditions were really important that had built in, I guess, a licence to be able to trial things. Now I am going to skip through a few things here. So what we decided to do in terms of the changes, I guess the first thing was to think about the changes to the structure of the visit itself and changes that might happen in terms of the language and the engagement that the assessor used in that approximate 1 hour of time they would spend in the household. And there were three particular techniques that have been shown in some other contexts and in the literature work pretty well. Descriptive norms, many of you are familiar, I think the language is more social norms, has been used a lot here in terms of telling what other people are doing and highlighting that it's normal to behave in a certain way. So if you imagine someone said, I think I could take a shorter shower, you say, well, great, well 45,000 other people are part of our program have said they could do that too. So we built that into the language. We used the commitment device. We know that commitments that are active, that are effortful, public, work really well. And there's a lot of research for many years that have shown that. And so we tried to incorporate some commitment strategies whereby we, after an analysis of some of the behaviours that they could undertake to save energy and money, we would give them a list of 10 and they would choose of their own volition 2 or 3 of those that they particularly found relevant or right for their personal circumstances. They would then write those down and stick them on the fridge or in some place in the household. The third thing we decided to change was to get people to talk in losses rather than talk in gains. It's a very, very difficult thing, in fact, in the training of the assessors or the retraining of assessors, this is easily the thing they struggled most with. Instead of talking about saving $135 per year by taking a slightly shorter shower, you're actually, by taking the shower you're currently having, you're losing $135 per year. Now we know that that works really well from lots of work, particularly in the behavioural economics area. So these were the 3 changes to the program itself, but we also felt that there was this real opportunity because of the rapport that was built up between the assessor and the client or the householder, that could be capitalised on. So we thought a re-engagement strategy may be quite useful. Now it's not normal practice for government to go out and re-engage with consumers or with the people they're servicing and spend money on that. So a trial was the right approach, and we had 3 things in terms of re-engagement: a second visit, a follow-up phone call, or an SMS from the assessor themselves. I'm glad this slide stayed because this is one that got cut, so it's still here. One of the really interesting things from this exercise was that we were trying to get assessors, some of whom have been in this program for 2 and 3 years, who had done well in excess of 1,000, sometimes close to 2,000 times, had been in people's homes and practiced the art of doing a household assessment and making recommendations. We were trying to change their behaviour. And we know from habits that they're particularly hard to change. And I guess with the program coming towards its end, trying to motivate people to embrace this change and act differently was particularly difficult. So training, and I can talk more about that, and in fact some of these slides will now that they're in here. I'm just going to skip through these because we don't have a lot of time. But they're just descriptions and how well they actually got implemented. In short, we found that these sort of graphs that we've got here show that the assessors found it most difficult to implement. Sorry, I've forgotten what to. They certainly found it most difficult to implement the loss aversion, but actually when it went to practice, they found it not so hard. Most difficult to train for it. Okay, so, sorry, this is the long version. Okay, so the results of this trial show this. Pre-trial, we had, on average, people saying, or people who we contacted after their visit, saying they'd implemented about 1.24 of the recommended behaviours or the behaviours they'd chosen. Post-trial, that went up to 1.3 on average. But we do see some variation across the different follow-up treatment conditions. One of the interesting results is that the SMS performed no better than the pre-trial result, and that the phone call and the second visit certainly led to greater uptake of behaviours. I think it is important to know that some of the qualitative feedback that we got from this was that people saying, knowing that the assessor was coming back was kind of motivating in terms of doing the things that they said they would do. One of the points I would like to make, though, is that we implemented a regime whereby the supervisors of the assessors would go in and watch them and report on how well they implemented these strategies. And for the most part, we didn't get as high results as we would like. We would have loved it if everyone chose tips, wrote them down and stuck them on the fridge. In reality, about 24% of people did that. So there's a real lesson in that. We might assume that we might think that that's an unsuccessful result, but if you view that through a habits or behaviour change lens for a habitual behaviour, like the assessors had around how they were acting, that's a pretty good result. So it depends, I guess, on the lens through which you view it. I will skip through these as well, sorry. I did have a 5-slide version. So I just wanted to conclude talking about some of the findings and also about some of the lessons for government. So I actually might just skip to that last. I think one of the really important lessons for government is to have good partnerships. I think there's a group within the Office of Environment and Heritage who have had a strong culture of adaptive management. In fact, you'd probably think of it as the learn adapt part, but I think they bought themselves the licence to move from a learn adapt to a test learn adapt, and that's a really vital outcome, I think, in terms of the professional capacity of that group. I think another really important lesson for government is that retrofitting is difficult. So if you go back into change a program that's already there and existing and has a long history, you're always going to struggle much more than you would if you were able to train those assessors, for example, right from the start. And I think that's where I'll finish. I'll probably use my time, sorry.
Thanks, Liam. Thank you. Are there any questions people have for Liam today? Alex, got some down. Thank you.
One from Twitter about the lack of implementation, and actually about the use of an intention to treat trial. I'm elaborating a little bit here, but I guess implementing policy is always messy, and you can't guarantee that something will be properly implemented. So is it actually quite useful to test that and assume that that's not going to happen?
So the question was about intention to treat, I gather. So we pulled out the results of those in both actual treatment and intention to treat, and the results replicated pretty much the same. So we'd had a look at that.
Thank you. Any other on Twitter there, Alex? We've got one over here. If we can get a microphone. Great, thank you.
Thanks very much for the talk. I think it was really interesting what you said about messenger and the messenger effects of the assessor coming back. I wondered whether there are any instances where it wasn't the same person that came back and whether we noticed a different intention or stated preference to undergo some of the energy changing measures, or whether you consider that there'd be other policy areas where you could use a similar approach.
So it is a good question. In fact, in one of those conditions, it wasn't the same assessor who went back. On the phone call, it wasn't made by the assessor. We tried to arrange that, but it just didn't work in practice. It was the same person that went back approximately 6 weeks onwards from them, and the SMS was from them ostensibly as well. To your question about are there other contexts where, sorry, just to be clear on the question, are there other contexts where the messenger is really important? In that sort of service delivery? Look, I think we began to explore that in this trial here. I think it's absolutely right. The choice of interventions that we chose here, the evidence pointed us in that direction. It was very clearly saying that there was this rapport and relationship built up that was, I guess, to some extent going to waste. Would it be equal in another context? I don't know. I think that's something you'd have to test and trial.
One more question, thank you.
Hi, Lani here from Department of Environment again. I'm just wondering, Liam, you were saying it's difficult to retrofit programs that already exist, but then in some ways you've got the problem identified there, and you can do research on the barriers, whereas with new programs you don't yet know what the problems and barriers might be. So I just wondered if you could elaborate on the benefit from focusing on new policies or new programs rather than looking at existing ones.
So I think the benefit of focusing on new programs would be that you can learn from programs like this and realise the importance. We've talked a little bit in groups and tables around the idea of shaping people in inceptions and the difficulty in breaking habits. If you can set those from very early on using best theory and practice right from the get-go, I think you're in a much better position from the beginning. Your point is taken, though, that this was a program that we were able to assess and learn from and then try and retrofit. I think it was particularly problematic just because they, assessors themselves, were so ingrained in their routines. Where that wasn't the case, and indeed we've seen some examples, plenty of examples today, where we haven't relied on a secondary or an intermediary to get straight to the consumer, and they clearly lend themselves to retrofitting better than this program. So I think there are some conditions where that's true and others where it's not.
Okay, thank you. If you'll join with me now in thanking Dr. Liam Smith. Thank you. Okay, our last speaker today is Jerril Rechter, who's the CEO of Vic Health. Jerril has extensive experience in leadership across the NGO and government sector and brings her experience in health promotion and digital communications and social media to her role as the Chief Executive of Vic Health now. Thank you.
Thank you. I don't know about you, but I haven't spent this long sitting down in one day since probably the last conference I attended. So if you wouldn't mind, I need you to stand up, please. I love the way everyone's sitting at the back of the room as well. It's really nice for a speaker to have so many people at the back of the room. Take whichever hand, I don't mind, your right or your left, out in front of you, and just draw your first name in the air with your right hand. Some of you are short, some of you are tall. The other one, your surname with your other hand, please. Get it moving. And then I think because we've heard the name Rory so many times today, I think we should just all draw it with both hands together, because he's obviously a really important person in the house somewhere. So thank you. You can grab a seat. One of the things that we do at Vic Health is if someone's doing a presentation or they're in a conference or whatever, is they can stand up anytime they want. This is not a ploy to get all of you to stand up and just give me a standing ovation. But if you do feel like standing up, moving to the side of the room, just stretching your legs or whatever, please feel free to do that, because that's something we do in our organisation. So thank you very much for the opportunity to speak today. And there is also, I need to warn you, there is a presentation gremlin in this room, because my presentation also isn't the version that I sent through on Friday. So we'll just go with the flow, see what happens, but I'll also make available to the conference organisers the proper presentation, so if you do want to have a look at it, you can. So the business of Vic Health is to influence health behaviour of individuals and communities, as well as the living conditions that influence their health and well-being. The ability to identify and prevent the negative influences of ill health and to champion positive influences is core to the Vic Health agenda. And it's impossible to think about the most pressing public policy issues without thinking about the behaviour of individuals. And health promotion that goes with the grain of how people behave, that respects their autonomy, absolutely makes sound sense. Vic Health, for those of you that don't know about us, was a world first, and it's the founding agency for taking a health promotion approach to prevent chronic illness from non-communicable diseases such as heart disease and cancers. The things that are as much a product of the environment as much as the everyday choices that we also make. So in battling smoking back in 1987, we were founded, it was out with the Marlboro Man and in with quit and plain packaging. And the Vic Health journey has many great success stories and is always innovative. But the world that we operate in today is very different to the world of Vic Health's 1987 genesis. The context for health promotion today is increasingly complex and global. The world is well and truly connected, and there are now 2.7 internet users worldwide, and that's 39% of the world's population, and we're racing towards 5 billion people connected globally by 2018. So getting information out there is no longer the problem. It's how we view it, where we find it, and how we validate and sort through the avalanche of information that confronts us daily. That's the big challenge. The implications for health promotion are huge. So consumers of information are no longer passive observers. We've heard a lot today about that co-creation and co-design. They're active contributors.
For our launch event last
See, there's
June.
just something going on in this room today.
Funding from the Australian Department for Foreign Affairs.
Oh, okay. Don't know what that is, but it was something exciting. I don't know what that was, but anyway. We've heard a lot today about the active contributors who co-create knowledge and evolve markets and influence governments. So from our perspective, back in 1987, no one knew what health promotion was, and people get health promotion now. They want more and they want better information, and they want to make choices that align with their own motivations. Individuals want to own their own health and well-being. And it's not just individuals, organisations from all spheres of life that we've heard about today, from governments, but also the not-for-profit sector, the NGOs, industry, business, entrepreneurs, and that huge machine that is the well-being industry are keen to offer support. So the gravity of future health, social and the economic burden of chronic disease is a problem that industry and organisations have shown a willingness to share, and it's a no-brainer really. A healthy workplace and a healthy community influences the physical, mental, economic and social well-being of all who live and work in it. And there's a broader benefit, because a healthy community influences the physical, mental, economic and social well-being, and I've already said that, so there you go, there's a bit of a gremlin, as I said. About this time last year, Vic Health released its action agenda for health promotion, and it's a blueprint for us for the next 3 years, but it also articulates strategic imperatives that are necessary to deliver the health gains that are required, and it's like a 10-year vision for health promotion in a fast-changing world. In this information age, Vic Health also aims to give people the tools necessary to increase control over and improve their own health. There are 5 key strategic imperatives, and I'll just touch briefly upon them before delving into a specific example of how we've used a new approach to health promotion in this information age. So for Vic Health, behavioural economics has a critical role to play in working with people as they make the life health decisions that will ultimately optimise their well-being. In brief, the Vic Health strategic imperatives are to promote healthy eating. So that's working with people to make better food and drink choices. Encourage regular physical activity, reducing the barriers to participation, expanding opportunities for sport, walking and everyday life. Continuing to reduce tobacco smoking, still the single most preventable cause of non-communicable disease in Victoria and Australia. Preventing harm from alcohol, and I'll come back to this and give you a bit of a case study of how we're working in this space. And finally, improve mental well-being, building resilience that we know is incredibly important in our young people so that they are less likely to end up with anxiety, stress and depression throughout life. So behaviour change is the biggest challenge for health promotion globally. Behavioural and lifestyle factors are major contributors to the disease burden, and most of the causes are well known, not just by professionals but by the general public as well. People know that smoking, not enough exercise and drinking too much is bad for you. That information is absolutely everywhere. But the lifestyle factors that impact upon our health and well-being are deeply entwined in the fabric of our everyday lives. We've heard about that today. It's changing behaviours. That's the really difficult part. To succeed in this, there's an app for everything in this world context. We need a strong and holistic evidence-based model for action, which builds on our solid base of skills and expertise, takes full advantage of our partnerships locally, nationally and globally, capitalises on Vic Health's capacity to influence policy, and importantly, is nimble and flexible enough to continually evolve. Our business model has 3 equally important and inextricably linked elements. The first part is to innovate, and that's taking advantage of the opportunities of social media and new and emerging technologies to explore bold new ways to address health priorities. To inform, ensuring that Vic Health's efforts reach as many people as possible using social marketing and public debate. And finally, to integrate. Integrating proven innovations into mainstream policy and practice. In thinking about the way that Vic Health establishes and delivers really good health promotion interventions, it's useful to think of our work as a bit of a value chain, to think through all the stages that we go through from raw product to end user. Only, of course, in Vic Health's case, the products are actually projects. There's social marketing campaigns, partnerships, or even brand new ideas that we want to test out in the health promotion marketplace. We all know the problems that we're facing. The real challenge is in how we approach them and deliver on the action agenda. So the Vic Health approach to our value chain looks a little bit like this. We innovate by designing and prototyping and testing new products in rapid timeframes. We inform by deploying our products into the field, taking a longer-term investment view and building strong evaluation into the scale-up of our projects. And we integrate, optimising our product outcomes and ensuring an effective exit strategy is in place. We want to make sure that we leave a legacy of partnerships, policy and best practice infrastructure which will sustain a benefit while we shift on to new and emerging areas to explore. From an operational perspective, we focus on all 3 parts of the value chain at exactly the same time. So what does this approach mean for Vic Health as it builds its capabilities and measures its success? Earlier I gave you the example of tobacco and quit because I think it's a really good story and also provides an insight into why we've actually changed our model of doing business. So I'll bring the Vic Health Innovate, Inform and Integrate model to life now by outlining how we're using our model in our strategic imperative to reduce harm from alcohol. So we've been working on alcohol culture change. I know it's a big thing here in Sydney, it's a big thing all over Australia, but we've taken quite a different approach in Victoria. As you know, or you may not know, through its links to injury, accidents, violence, and over 200 physical and mental illnesses, alcohol is one of the top 10 avoidable causes of disease and death in Victoria, and it's been estimated to cost $4.3 billion each year to the health and justice systems, workplaces, families, communities, and individuals in Victoria. The Victorian Government engaged us to lead an alcohol culture change program. And what we were seeking to do was change the way that people think about alcohol. Because in our view, paternalism and prohibition has never been the answer. Capitalising on new and emerging technologies and building on VicHealth's government and community links gives us the chance to make real inroads into a commitment to culture change. We commissioned some fantastic and really insightful research around problem drinking. We then engaged with the community in a social marketing campaign that asked individuals to name the point in the night where clear thinking turns into risky drinking, to make a culture change commitment around alcohol consumption. The Name That Point campaign was initially targeted to create a community dialogue. It generates a social movement through using efficient online social marketing channels to reach our target demographic of 16 to 29-year-olds and get an understanding of their knowledge and the attitudes so we can guide them in owning and addressing the problem to change behaviours. Name That Point is an approach that is evidence-based, it works individually and broadly with the community, and it's focusing on driving better drinking behaviour. In the long term, we're targeting a 10-year culture change through this project. But there are some other things that we're doing in the innovative space that really showcase the increasing importance of behavioural insights in our work. As a part of the Name That Point campaign, VicHealth gave a small grant to an innovative young group called Free is Better. Free is Better hand out bottles of water for free, and they fund those bottles by selling the advertising spaces on their bottles to health-conscious organisations. The bottles are environmentally friendly, and with the VicHealth grant, Free is Better put the Name That Point advertising on their bottles and handed them out to people at nightclubs and bars, giving people the choice to have a sip of water instead of a glass of alcohol. It was a great idea, but how do we scale it up that it will be sustainable over the long term? In the lead up to the campaign, our approach was informed by the 2012 VAGO report that highlighted the concerns about the lack of data sharing between government agencies. VicHealth saw an opportunity to collaborate, and we suggested that the Victorian Commission of Gambling and Liquor Regulation geocode all of its licensing information so that it could be used by local governments, by the community itself, and also by researchers to more actively plan and understand how many alcohol outlets are operating in their community. Connecting the dots, then the Emergency Services Telecommunication Authority, ESTA, recognised how important this information would be to their work. Until this project commenced, ESTA would receive calls from people out at venues and bars, probably, you could be safe to say, a little bit intoxicated, and they were requiring an ambulance or police to attend, but they were unable to provide the street address, only the name of the bar or the club that they were in. So this meant that ESTA operators lost valuable time finding the street address of the venue before they could actually send out ambulance or police. So through the geocoding of the liquor licensing data, ESTA can now respond to calls from people out at pubs, bars and clubs much more quickly, potentially changing the severity of an alcohol-related injury or harm. We might not have changed the amount that people are drinking out at night, but by recognising the need for change and also the possibility for collaboration, we were able to invest in the project that could make a real impact on reducing alcohol-related harm. Just in finishing, back to our water bottles and human behaviour. You can certainly lead a horse to water, but you cannot force it to drink. One intervention we're about to launch is a look at the factors that influence people's decision to increase their water consumption when in licensed premises. We have a hypothesis, we don't know the answer, just a hypothesis, that the mode of supply of water will influence demand for water. It's still in the design phase, but we'll be trialling 3 different interventions on 3 different premises to gain an insight into what will roll out more broadly after the trials. Our evaluation will be conducted by observing patrons, conducting intercept surveys of patrons leaving venues, and also talking to premises owners. We're also focusing on the supply of water from a different angle. We're launching a campaign to see if the availability of free water can reduce the consumption of soft drinks or sugar-sweetened beverages. So thinking about how people make choices has relevance for healthier food and drink options as well. We're in the midst of developing this intervention about how you can design and implement water fountains in public spaces, and we're connecting artists and service designers to see what will make people choose free water as a healthy option. Innovate, inform, integrate, and importantly, evaluate within a framework that explores everything we've heard about today that are the important components of behavioural economics. Some of the things we're trialling are nudge tactics. Some are a little bit different, but what they rely on us doing is creating evidence fast to inform action and results. And I think that that's something that really resonates with me around behavioural economics and how it can shape better health and well-being. Thank you.
Thanks, Jerril. Have we got some questions for Jerril? We have a few minutes. Great, over here. Got the microphone coming around. Down here, this gentleman. Thank you.
Thanks very much.
Just keep talking.
I can talk loud enough anyway, I think. Thanks very much for a great presentation. I'm just wondering, you're obviously doing quite a bit of profiling of your client base, because the messages and the strategies you're using are clearly directed at very particular groups. Could you just give us a little bit of detail of the different profile groups and how you're actually coordinating that profile?
So you mean in terms of market audience segmentation, is that what you mean?
Yes.
Certainly with the Alcohol Culture Change program, it was really clear that 16 to 29-year-olds are the ones that have the biggest issue around loading up on drinking. So pre-loading before they go out, side-loading in between venues, and also post-loading after they've been out drinking for an entire night as if they haven't had enough drinking already. So we were really clear that that was actually our target market. And we've just got the results back from that particular part of the campaign, and it's been hugely successful. They've surpassed all of the targets that we ever imagined that we would reach. But also, interestingly, it still had a whole of population approach as well. So we were able to clearly see that we were targeting our target market, but also via the way that we were able to do the evidence, we could see that it was reaching a whole of population. And whilst we didn't actually aim to have people reducing their drinking, that wasn't the aim of the campaign. The campaign was really to start this dialogue and this conversation so we could actually really understand what would resonate with younger drinkers. We've just found out that out of every 10 people that participated in the campaign, 3 actually changed their drinking behaviour during it, which was quite extraordinary and something we didn't expect. So the next phase of this that we're rolling out will start in September, and we're in testing at the moment. So all of that evidence that we built is now going into the next phase of this campaign. Other programs target different markets, different market segments. And we're still in the very early phases of designing some of our work around water consumption, increased water consumption, and also mental wellbeing. So we'll probably look at different market segments as we're designing those programs.
Could I just, give you a quick follow-up? In terms of the lower socio-economic groups, because again, they're very slick programs, they appear to be. But for people that don't have those numeracy literacy skills, have you done something particular for those groups?
Yeah, look, I think probably the best work, or not the best, we have a health equity team at Vic Health, and they look at every single project that we do and build a health equity component into every part of our framework. I think probably one of the best examples for me is within the smoking context, and we've been funding QUIT since our inception in 1987. And we know that the people that are still smoking are the ones that are probably low SES within the community. And so really changing the way that we're supporting QUIT to make sure that it's targeting the lower SES groups is incredibly important. And again, we'll just continue to build that into all of our programs as we go along. But very good question.
Thank you. Alex, you had one over there.
Yeah, a very direct question here from Twitter, but just says, why has behavioural preventative medicine been neglected in health for so long? And what are your thoughts on it?
Why has what, sorry?
Sort of preventative behavioural medicine.
Been neglected for so long? That's the great question, I think. It's, you know, if I put myself in the shoes of governments and ministers, the front page is not about prevention, it's about hospital beds and emergency waiting rooms and ambulances. So, and I guess we're lucky in Victoria that Vic Health has been going for over 27 years now, and we do have a great brand. We're very trusted in Victoria. The messages, the evidence that we produce is very robust. So I think we're in a very fortunate position, but it is very different in other states and around the world, and I understand that. But I can't give you a good answer for that one. I'm sorry.
I'll just point out that Cliff has a few thoughts on that one. If we can turn Cliff's microphone on, if that's possible.
Great.
I'm not sure I've got all the answers. One of the issues is the definition that clinicians often use for EBM. We talk about evidence-based medicine all the time. The clinicians actually have a different one. It's everybody but me. My patients are different. I'm the only person who's on Friday night. I get the difficult cases because I get the best results. And they have a very insular view of systems issues because of the way they work. Clinicians inevitably work one-on-one, unless they go into public health or somewhere else like that. And so they've changed the way they think, and I think it has reached a stage where it undermines the real principles of evidence-based medicine. And we have to bring that culture back into using the evidence of many, many thousands of people and many, many programs, such as you've shown, to actually change the one-on-one contact we've got with our patients. And that's the real challenge in health.
Thank you. Thanks, Cliff. If you'd like to join with me now in thanking Jerril for a presentation today. Thank you.